All right. Well, splendiferous. We made it through the morning or afternoon or evening, as the case may be, depending on where on the planet you happen to be. And you can see that I have moved now from the Katmai Peninsula of Alaska to Mauna Kea, the observatory in Hawaii. And why have I moved to this observatory? Because some of our speakers are missing, and we suspect that they may have been kidnapped by space aliens. And so we're going to look into the heavens and see if possibly we can find those who haven't made it yet into the Zoom room. But in the meantime, what we're going to do is try to address a few of the questions that have been submitted through the question box function on the website. And these are questions that are directed to specific individuals who have given talks. And I'll try to tailor this so that I'm not addressing questions to people who aren't actually here, that are off in outer space or wherever they ended up going. And I'll direct it to people who actually are here on the call. And probably just because I'm kind of a linear kind of guy, I'm going to end up addressing these questions in the order in which you spoke. Just because that's pretty much the order that they've come in on this Google Doc that I have. So with that having been said, let's get at it. So our first question is to Dr. Sharma, and I see that he is here. I don't know what time it is in India. I imagine it's like 10 o'clock at night or something like that for him. The first question for him is the picture that you showed on your slide, one of the pictures that you showed, was very similar to PAN. How to make the diagnosis in the absence of enzyme estimation, which is not available at most places in India. So I guess the question really is, how are you making the diagnosis of DADA2 when you're not able to measure enzyme activity? Dr. Sharma, do you want to answer that brain teaser?
Oh, am I audible?
Oh my goodness, now that's great, fantastic.
Sorry for the
how do you make the diagnosis when you don't
once
have
again,
enzyme
sorry for
testing?
the technical issues. I'll quickly go over again. The issue is when you have a younger patient, say children, young adults with exuberant, extensive livedoid rash with dominant CNS manifestations, always keep it as up amongst the differential diagnosis. That's what our experience is. Having said that, phenotypically, it is practically impossible to differentiate between the DADA2 and a classical polyarteritis nodosa, which is non-DADA2. So, I would, given a chance, I'll probably test with in everyone. But these are the soft pointers which would point towards DADA2 over classical polyarteritis nodosa.
And do you have genetic testing that is readily available to you?
Well, initially we were sending the samples abroad, but now we have the facility to do it in-house at our own institution, which we've established. We don't have the facility to do the ADA2 level. So thanks to Chip, who's helped us. Initially we were sending the samples to Dr. Mike Hirschfield, but now we have wonderful person, my friend Pui Lee, who is with a very quick turnaround time, we are able to do these ADA2 estimation at Boston. I think that's what it is.
Okay, well, fantastic. So another question addressed to you is from Marco Gatorno, and he wants to know, given the fact that thalidomide has a good anti-TNF effect, could it be useful when anti-TNF drugs are not available?
It is always a challenge to continue thalidomide on a long time because of the side effect profile that we have. If it was an illness where we were looking at short-term use of an anti-TNF, probably it might have been a good choice. But realistically, herein where we are looking at the lifelong treatment, perhaps, if you are in despair, there is a life-threatening situation and you can't use anything else, probably there you can use it to tide over the crisis, but it can't be used forever. That's
Yes, absolutely. Do you have any experience using it in those kind of in a pinch situations?
Not
No.
not really.
Okay. All right. Okay. Well, now here's a question from my colleague at the NIH, Peter Grayson, who first of all congratulates you on a wonderful talk. And then he's asking, why do you think you saw increased prevalence of DADA2 at older ages in your cohort?
Well, I don't really know the answer why. The question when we started thinking was when we were referred the patients of polyarthritis nodosa which were not responding to cyclophosphamide, which when they came to us, we thought, could it be DADA2? That was our first experience when we were doing it in adult patients. What made us think was that people have tried everything else. People have tried cyclophosphamide, which is our best bet, and still it doesn't work. Could it be DADA2? Once we started getting the reports of those more and more, and then when it was in a particular community like Jain or Agarwal community, anybody with strokes, and more we got, more we were thinking about this, and then over a period of time we collected quite a few number of adult patients.
So they were just sort of hiding in plain sight, if you will.
Yeah.
Okay. All right. Well, let's see. I have one more question for you, Dr. Sharma, and that is, did you have patients on non-biosimilar biologics, such as Humira, rather than Amgavita, and did they have a better outcome? In other words, is the standard drug better than the biosimilar?
Well, we don't have Humira available in India. We only have a biosimilar adalimumab available in India. But in our cohort, we have the data is from different centers. People have used innovator drugs also, and we ourselves have used Enbrel, we've used Remicade, and we've used biosimilar adalimumab and other biosimilar drugs also. I think the numbers are too small for us to really have any analysis from that perspective. Majority of the patients have had biosimilar drugs. We only had a couple of patients which I've shared who have had a relapse while on, and the girl who has had relapse, she received both innovators and biosimilars. In fact, she first received Enbrel and then she received biosimilar adalimumab, and I think then she received golimumab, which is innovator, and then eventually she is now on Remicade. So we've used all in that girl.
All right. Well, thank you. All right. Well, now we're going to move the hot seat. Isabel, you are now on the hot seat. So the first question for you this is a very brief question. JAK-STAT inhibition, next on the horizon?
Well, thank you, Dan, for the question. And so maybe, yes, I would say, I know there have been attempts by some people to try JAK-STAT inhibition in the cytopenia cases with ADA2 deficiency, some with success and some not with success. It needs to be published and it needs to be followed longer, but I think the bone marrow findings are giving us some hope that it might help. And maybe in instances and in patients where we don't have any effect of other drugs that we are using, and if we are not willing to go to transplant. So I think it's an option, yes.
All right. Okay. Thank you very much for that. Now, the next question to you has to do with the warts that you showed on your slide. Are the warts presumed viral in etiology? And if so, is this all molluscum, or is there a concern about HPV as well?
So there are both mollusca and HPV. So we have done actually PCRs to prove that the origin was indeed HPV in some of the patients. It also has been done in the NIH patients. I think also Bodo has in his cohort of patients, several patients with warts. So what is the pathophysiology here? It's quite unclear. We did some in vitro testing to see what would be, the problem, but we couldn't nail it down right now. It could be a problem with some sensing intracellularly, but we haven't actually been able to trace the pathophysiology down. And the question is also if it's really enriched as a feature in ADA2 deficiency. Maybe not the incidence of warts, but that there are refractory warts probably is. If that is a good answer.
Yes, yes, yes. And the questioner also raises the issue of whether you would be thinking about vaccination strategies for HPV.
Yeah, exactly. I think that makes a lot of sense. And we haven't done this in our patients, but I do think that these patients really need careful follow-up for HPV-related complications later on in life, like in other patients with severe warts in the context of immune dysregulation.
Okay. All right. Well, there was another question about JAK inhibitors, but you've already addressed that. And then there's a question about the interferon signature and whether that was measured in total blood, PBMCs, or monocytes.
So we actually studied both, and actually both in peripheral blood, in whole blood, and in PBMC, there was an increased type 1 interferon signature. So as I said, this is not new. It has been reported by several groups, but I decided to follow that actually longitudinally in the patients prior to and during treatment. And it was actually quite striking that the asymptomatic siblings had a lower interferon signature than the affected ones, and that it seemed to have something to do with disease activity. But of course, we need many more data, and not from a small cohort as I have here in the hospital and in Belgium. So I think if we put everything together, maybe we can come up with some theory there. But I do think it's an important pathway. Well, you will hear more from this from Bodo as well, I guess.
Yeah, it seems that this is really an opportunity for us, just thinking about it together, for others to, in their cohorts, look at this as well and see, how generalizable it is and whether there are genotype, phenotype correlations, et cetera. Okay, yet another question for you, Isabelle. What is the incidence of lymphoproliferation or lymphoid malignancies in ADA2 deficiency?
Well, lymphoproliferation seems to be quite prominent and was probably underestimated in the previous cohorts and in the previous patients' reports. So I would say at least 50% would have hepatosplenomegaly and lymphadenopathies. Now, what is the prevalence of lymphoma, leukemia, etc.? That's a very, very difficult question because there is no study apparently available right now that looks into ADA2 deficiency at the enzymatic level or at the genetic level in any cohort of patients presenting with Hodgkin lymphoma, non-Hodgkin, etc. And all of these tumors, AML, TLGL, etc., have been described in association with ADA2 deficiency. So I think we actually don't know. And I think many patients could be undiagnosed, like presenting with childhood lymphoma, etc., which are the more rare presentation. So I have no accurate number. As I said, it's a chameleon disease, and you would have to test almost anyone with some specific feature, because it can be one feature that is the hallmark of the disease in one patient.
Yeah, well, it really sounds like it would be an important question, that would be worth addressing by someone looking at cohorts of patients with some of these cancers and seeing whether or not there's an increased frequency of ADA2 mutations amongst them, because that's what one would really have to do in order to answer that question. Okay, well, let's see here. I think that I'm going to take you off the hook. Now I'm going to just address a general question, actually from one of our speakers, but I won't say who. This question is, should not all children with vasculitis get an exome? And rather than posing that question to the person who asked it, that would be mean. I think I will instead ask Pearl, Ching Zhao, can you please answer that question for us? And you may not have been paying attention because after all, I did say that we were going to do this in the order that you spoke. So you may have been thinking about something else. But here's the question again. Should not all children with vasculitis get an exome? Pearl, what do you think? You have to unmute yourself. Yeah, you're okay now, I think. Oh, no, you're still muted. There you go.
Is it okay?
It's okay. Good to hear your voice.
I think, yes, we should sequence all of the patients with children with vasculitis. I think not only DADA2, there are other genes. Of course, vasculitis patient, there's a large number of the patients with DADA2. So I think right now we are already at the age or time that any patients with whatever vasculitis, immunodeficiency, autoinflammatory disease, these patients should all be sequenced with exome or even with the whole genome sequencing if we cannot find the answer by whole exome sequencing.
All right, well, that sounds good. So you answered that question. And of course, the follow-up question is, where do you draw the line? Should we just do exome sequencing on everybody, or at least on people that have, some symptoms of something?
I think right now it's hard to say. My line is everybody.
I thought so.
Previously, we always think of early onset or very severe patient or some with some family histories or consequences. We think these patients may have genetic contributors. But right now, when we sequence more and more patients, some adult patients, some late onset, some even very mild phenotype patient may have may identify the mutation. So I think anyone patient should be sequenced.
All right. Well, I agree with that. But of course, there's just the issue of availability and cost and so forth. But in a perfect world, we could say that anyway. All right. Well, thank you, Pearl, for going on the spot like that. Anyway, now I'm going to turn the spotlight on Samantha Kure. And the question being directed to her is, what made you select adalimumab over etanercept as the primary treatment? Samantha, explain yourself. Why did you do that?
Thank you. Can you hear me?
Yes, indeed. Yes, we can.
So I think there's in the UK, great. I think there's a slight preference for adalimumab. It is more expensive, but there's a slight preference for it. As you know, etanercept is a fusion protein of the Fc portion of the antibody chain with the TNF receptor. So it's actually a fusion protein, whereas adalimumab is a purely human monoclonal antibody. So there is a slight preference given the sort of consensus opinion that there's a lower likelihood for the development of anti-drug antibodies. So, yeah. Okay,
so that was your reason. That sounds like a good answer. Okay, so let's see. Oh boy, you have another question here. These interrogators are, really caught up on this adalimumab business. Any problem of antibodies against adalimumab? This is a real possibility in other conditions. Adding methotrexate?
Yeah. Yes. So, as you know, some of our patients transition to adult care and are being looked after now at their local sort of regional centres. And each centre, the actual monitoring of problems of with adalimumab is very regional specific. We at GOSH are obviously still looking after the paediatric patients. The paediatric patients themselves tolerate adalimumab very well. However, some of the adult patients who are, some of them are quite old now and have been on anti-TNF treatment for quite some time, we're starting to see issues with those patients at the regional adult centres, and they're starting to have to add in methotrexate. They're starting to have to add in other DMARDs as well to try and manage not vasculitic features, but largely inflammatory features. So fever, joint pain, rash, that kind of thing. And unfortunately, the monitoring, and perhaps this is a matter for discussion, but the monitoring of anti-drug antibodies is not widely carried out across these centres. But perhaps it's something we should be doing more routinely, because I think there is a suspicion that the efficacy of anti-TNF treatment is beginning to wane in some of these patients. There is also the confounding factor that some of the adult patients are not as compliant as in our paediatric cohorts, where the parents are a bit more on board. And I'm sure some of the other physicians here may have experienced that. It's difficult for me to say precisely, because the practice varies across 6 or 7 centres who are looking after these patients.
Yeah, do you ever swap one monoclonal antibody for another? You know, like going to golimumab if a patient seems to have problems, develop problems on adalimumab, for example?
Yes, I mean, I don't think there's only been, in our cohort, there's only been one patient that was switched from, one adult patient was switched off adalimumab to etanercept. But we don't routinely use golimumab. Some of the older patients started off their journey on infliximab and have been through, infliximab, etanercept, and now on adalimumab. So the largest proportion of patients are still on adalimumab. Very few and are stable on that, and very few switch off that. But as I said, there is this concern of where you go next once you're starting to have to add in methotrexate and other drugs to control the inflammation.
Yeah, okay, well, thank you, and that's a very thoughtful answer. So in any case, let's see, what other tricks do I have here? Oh my goodness, here's a question to me. Am I aware of any DADA2 patient having COVID-19? And if so, what was the outcome? And to be honest with you, I'm not aware, at least in our cohort, I'm not aware of any patients who have developed COVID-19. And in fact, even in our broader autoinflammatory clinic, we have not really seen any patients, known of any patients anyway, that have developed COVID-19. But maybe I should just throw it open to the rest of you all. Have you seen any patients with COVID-19 amongst your DADA2 patients? Alexander is giving me a thumbs up. Alexander, take it away.
No, thank you. Thank you, Dan. No, that just we get one single patient. This was an adolescent with very mild symptoms of COVID-19, and the rest of the family was safe as well. So it doesn't seem, well, only on one case, it doesn't seem to be particularly dangerous. And again, the pediatric age is so protective. I guess for children, it doesn't seem to be a big matter, but based on only one observation, it's too small but effective. But yes, one case in France.
Okay, all right, thank you, Alexander. And Cesar is raising her hand. Cesar.
We haven't had any, but last week we were talking with Benedict Nevan about the interferonopathy patients, and she had 3 patients who had COVID and had interferonopathies, and all of them had very, very mild disease, almost asymptomatic. So I guess if you have high interferon, you're giving a good fight against COVID. I mean, at least theoretically. So we haven't had any with COVID, but maybe if they did, they wouldn't be so, such tough patients because they have high interferons, is my guess.
Yeah, that makes a lot of sense, Cesar. I think that's at least a good way of thinking about it. Okay, let's see here. What other tricks do we have in our?
Both of
Dan, while you're looking, Dan, I have a question to Cesar's comment. I like very much also this comment, but in light of this, should we maybe think of screening our patients for an inapparent COVID-19 exposure by possibly antibodies in the ones who still have an antibody response, or by specific T cells in the ones who do not have an antibody response? Because they may have had COVID and we haven't realized because of their great interferon response, they were not symptomatic.
It's a good point. It's a very good point, Bodo. And certainly if we could get ourselves organized, I think that would be a very nice idea, a good project to do. Okay, so now let me see. We're getting close to the time when, you know, the witching hour or whatever you want to call it, when we all turn into pumpkins or whatever we're going to do. So here's the next question here. How should we follow if enough anti-TNF coverage is present in an attempt to prevent ischemic events, or in those rare patients that happen where it happens while on anti-TNF treatment? So this is directed to Sam.
Could you say that again? I couldn't hear that.
Oh, yes. You're just
Sorry.
sort of bargaining for time, I can tell. So the question was, how do you know whether somebody's on enough anti-TNF treatment?
So we, in the pediatric, I mean, I've got most experience obviously with our current patients at GOSH. And normally, obviously, they're monitored fairly closely, and we increase the dose by weight, you know, for the adalimumab. And they're monitored using, well, essentially what is the PVAS scoring system, and monitored for, you know, the inflammatory and vasculitic features every time they have a clinical review. And obviously the talking to the parents and seeing what their opinion is of how the child is performing at school, etc., and general well-being. And then the decision is made by the clinician as to whether to do a dose incrementation based on the features that we're monitoring. That's generally how it's done at Great Ormond Street.
Okay. All right. Well, thank you. That sounds reasonable. And at this point, I think we've only got like a minute and a half left. So let me see if I can come up with a good question here. Does anyone have any idea with regard to ADA2 mutations in patients with large cell leukemia, T-cell large cell leukemia? And I don't know, is Jana there or not? I guess maybe, is she there or she's
yes, not? I am here.
Oh, okay. Sorry, I just didn't see you.
Too many faces on the screen.
Yeah. Okay.
Yes. So 4 of our patients have TLGL cells, T cells, in the bone marrow and liver, and they all have the Finnish major mutation, so R169Q. But I don't know whether that's actually connected to it, or I can't tell, as all of our patients have that mutation. So hard to tell.
Yeah, that's true, since that's your population. The R169Q variant or mutation seems to be a founder mutation in the Northern European population. And I suppose that even, you know, one could think about whether there could be, you know, some modifier gene or whatever that predisposes to that condition in certain populations. And that would be potentially a population-specific effect as well.
Yep. We have looked into the patients that do have the LGL cells, and they don't at least share any modifying genetic factors. So then they would need to be independent modifying factors. So there are nothing shared.
Okay.
May I
Yes, 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 Marco. It's wonderful to see you. You know, you were one of those that we got out the space telescope looking for you because we thought that you had been kidnapped by space aliens. So please.
I'm here with the clock of Data 2, and so I'm that is always there, Chief, always.
Not just on this call.
Not just always. It's locked, but it's no, I have a question also for Gianna, but also for okay, also Jakob. I have a question for Gianna, also for the other one, because I mean this is particularly intriguing. I explained also to you the experience of this patient that was very mild with just some cytopenia and lymphoproliferation. That was the cause for the bone marrow aspiration and the study on bone marrow. But now my question is, do you think that there is a room for including the evaluation of bone marrow at the diagnosis in ADA2, even in those patients that have just a, let's say, inflammatory phenotype at the onset?
Ah, now that's a good question. I'm glad that you asked Jenna and not me.
Indeed a good question, and we did see in the pediatric patients already very early on lymphadenopathy that was kind of potentially hinting that there might be something ongoing, but initially they did not have. But within a few years, when the disease developed, then the LGL cells were found. So I think it might be worth doing that if you have lymphadenopathy and large spleen, large liver. But I'm not the clinician who would be able to do that call.
All right. Well, it's a good question, that's for sure, and certainly food for. Oh, it looks like Bodo wants to say something. Bodo.
Thank you. I actually have a follow-up question on Marco's question. May the hypogammaglobulinemia be the consequence of bone marrow involvement as well? Because maybe the inflammation in the bone marrow may cause the plasma cells to not feel well anymore.
Yeah, good point. Good point. All right. Well, at this point, we actually have gone over by 3 minutes. Nothing seems to have happened to us because of that, so that's good anyway. But I think that I need to call things to a close.